was really interesting. I'd now like to invite Ms. Angela Hamie. Hamie? Thank you. To present on pediatric transplantation, exploring the influence of age, thymus excision, organ type, and immunosuppression on the lymphocyte population. Angela has just graduated from the University of Alberta and holds a Bachelor of Science with honors in Immunology and Infection. Her presentation will summarize her research conducted throughout her fourth year on undergraduate thesis project, which focuses on the age, thymus excision, organ type, immunosuppression, and lymphocyte subpopulations in pediatric transplantation. Please, Angela.
Okay, hello everyone, and thank you very much for the introduction. So do I connect it from here? So my name is Angela, and today I will be presenting my undergraduate thesis project, which explores how the influence of age, thymus excision, and organ type, and immunosuppression affect lymphocyte subpopulations in pediatric transplant. So as you can see in this figure over here, there are many factors that interplay to shape the immune response following solid organ transplantation. But today I want to zoom in and discuss 3 significant factors that our research specifically dived into. And these are immunosuppression therapy, age, and thymus excision. Over the next few slides, I will delve into each factor and explore their impacts in transplantation. So as you can see in this figure over here, immunosuppression therapy, as you all know, is essential for preventing organ rejection. However, a delicate balance must be maintained in order to avoid adverse effects. Our study compared the effects of 2 primary types of immunosuppression, anti-thymocyte globulin, also known as ATG, along with basiliximab. Anti-thymocyte globulin is a polyclonal antibody that binds to various antigens on thymic cells, which typically lead to their depletion. On the other hand, basiliximab is a monoclonal antibody that specifically targets CD25, also known as the IL-2 receptor on activated T cells and regulatory T cells, which inhibits IL-2-driven T cell proliferation. And of course, while these therapies are crucial, they also do increase a patient's susceptibility to infections and even malignancies. And currently, immunosuppression medications are currently determined by patient's weight or aimed at reaching predefined plasma levels. Additionally, management strategies also do differ between centers and frequently rely on a one-size-fits-all approach rather than being customized to meet the unique needs of individual patients. So with this study, we aim to take steps towards addressing these limitations and advancing personalized therapy. So moving on to pediatric populations, clinical data has suggested that there are 3 distinct maturation periods that the immune system goes through, starting from infancy from 0 to 2 years of age, toddler to school age from 2 to 10 years of age, and adolescents from 10 to 18 years. Specifically, patients under the age of 5 have been shown to have higher survival rates than their older counterparts. While this is not fully yet characterized, it is thought to be due to a more malleable immune system, along with the composition of their immune system. Pediatric patients also show a natural delay in response to polysaccharide antigens, which is associated with low levels of CD21 expressing cells. This phenomenon is also thought to explain the reduced response to ABO antigens, allowing blood group incompatible transplant at this age. And finally, looking at thymus excision, pediatric cardiac recipients also undergo thymus excision in order to enhance their surgical visibility. However, the thymus is an organ that is crucial for T cell maturation, and this removal has been shown to lead to reduced levels of naive T regulatory cells. These patients have also been shown to have an elevated incidence of atopic diseases, including asthma. And in our study, the thymus was not removed in liver transplant recipients, therefore they will be used as a point of comparison. So with that, our research hypothesized that the composition of the adaptive immune system, both before and after transplant, will be influenced by age, immunosuppression, and thymus excision, and will therefore impact the clinical outcomes of transplant. Our first aim was to conduct a comprehensive cross-sectional analysis in order to evaluate how age, thymus excision, affect the lymphocyte populations prior to the initiation of immune suppression. And our second aim was to examine the effects of all three of these factors on lymphocyte phenotypes throughout the post-transplant course up until 1 year post-transplant. So this slide just shows our patient demographics. In our study, we had 115 patients that were listed for either heart, liver, or kidney transplant. Notably, one thing to focus on is the age distributions. Looking at our kidney transplant patients, they had a notably higher median age at around 10 years, while those receiving heart and liver transplants were younger, with a median age of approximately 2 years. Induction therapy also did differ among the organ types, with more heart recipients receiving ATG and more kidney recipients receiving basiliximab. So this project was all conducted within an arm of a Canadian national collaboration, which is called the POSITIVE Study, standing for Personalizing Immunosuppression to Improve Efficacy. And again, we had 115 patients listed in this study. We collected blood samples and clinical data at 3 stages: pre-transplant, 3 months, and 12 months post-transplant. From which peripheral blood mononuclear cells were isolated and subjected to deep immune phenotyping. And in order to identify our populations of interest, we utilize specific cell surface markers. We use classic markers to distinguish between T and B cells. Regulatory T cells were characterized as CD4 positive with high CD25 expression and low CD127 expression. Transitional B cells, which are thought to have immune modulatory effects, were characterized as having high CD24 expression and CD38 expression, and regulatory B cells, as have been observed in mice, as CD5 positive and high CD1D expression. And in the upcoming slides, I will be presenting the lymphocyte populations that show our most significant findings. Starting off with our T cell population, which again was characterized as being CD4 positive. If we draw our attention to the top left graph, we can observe that the CD4 count was significantly reduced at 3 months post-transplant, with a persistent reduction leading up until 1 year post-transplant. At the top right graph, we can observe that our kidney transplant recipients, which are represented in the blue bars, maintain a relatively constant CD4 count up until 1 year post-transplant. However, if you draw your attention to the liver in red and the heart in green transplant recipients, we see that they experience a notable decline at 3 months post-transplant. While the liver group recovers to baseline levels by 12 months, interestingly, the heart group does not recover at 12 months, which is thought to be an influence of the thymus excision. Drawing our attention to the bottom left graph, we can see that there is the most pronounced reduction in CD4 T cells among the infants, which are indicated by the blue bars. And moving to the bottom right graph, we observe that treatment with ATG, which is indicated by the red bars, leads to a significant reduction in the CD4 count by 3 months post-transplant, with no significant recovery by 12 months. However, treatment with basiliximab did not show any significant effect. Now looking at our B cell population, which were again identified as being CD19 positive. In the top left graph, we can see that the B cells exhibited a notable drop at 3 months post-transplant, with sustained lower levels up until 1 year post-transplant. In the top right graph, we observe that the CD19 counts are significantly higher in the liver recipients, which are indicated by the red bars, both before and after transplant, unlike in the heart and kidney recipients where no significant effect was observed. In the bottom left graph, we can see that the CD19 counts are initially highest in infants, which are again indicated by the blue bars. And in the bottom right graph, this graph reveals that both ATG and unexpectedly basiliximab treatment persistently reduced CD19 counts up until 1 year post-transplant. Moving on to our regulatory T cells, in the top right graph, we can see that the proportion of regulatory T cells increased at 3 months post-transplant. However, they did return back to baseline at 1 year post-transplant. Looking at organ age and induction, all three of these factors did not seem to have a significant effect on our regulatory T cell percentages. And finally, turning our attention to transitional B cells, in the bottom right graph, you will see that there was an increase in heart recipients, which are indicated by the blue bars at 3 months post-transplant. However, interestingly, there was a decrease in the kidney recipients at 3 months post-transplant. And in the bottom left graph, looking at age, we saw that the highest percentage of transitional B cells was in our infants, which is again indicated by the blue bars. However, our analysis indicates that changes over time and the effect of induction were not significant on our transitional B cells. So to summarize these findings, we found that helper T cells consistently declined over 1 year, especially in infants and following treatment with ATG. Our regulatory T cells peaked at 3 months and normalized at 1 year, but they were unaffected by organ type, age, or induction methods. B cells generally decreased with persistent drops post-ATG and basiliximab treatment and were higher in liver recipients and infants. And our transitional B cells were highest in infants, increased in heart recipients, and decreased in kidney recipients. Of course, our study did have some limitations. The first is that the lymphocyte distribution is affected by confounding factors. Further, since this was an observational study of a clinical population, we weren't able to account or control all factors, which may also play a role in lymphocyte distribution. And to conclude, our deep immune phenotyping has uncovered significant differences in lymphocyte composition, which were influenced by the factors that I discussed today. In our next steps, we hope to be able to correlate these findings with clinical outcomes post-transplant, including survival and rejection, and potentially paving the way to adapt patient management strategies to better meet personalized needs. And thank you very much.
Thanks, Angela. We'll now open up the floor for questions.
Hi. Hey. Okay, good. Well, thanks so much for that talk. My question might be naive, but it is, why do you think that the transitional B cells were higher in infants and hearts and lower in kidneys? Like, was that surprising, or what do you think the reason for that was?
I think in the infants, I do know that the infants do tend to have higher levels of naive B cells. So I think them having also a higher level of transitional B cells could just be an effect of their age. In terms of them being higher in the kidney recipients, that was something that I think that was unexpected for us. So I think it could be an underlying effect of maybe the condition that they had coming in before transplant. Also maybe could be an effect of their age as well, but that's something that we're still investigating. Thank you for your question.
Hi, thank you. It was a wonderful presentation. I have a question about your regulatory T cell population, because you say you saw an increase. You're looking at proportions, right? So if something goes up, something else goes down. Do you think it's an actual increase in your Treg proportion, or do you think because of immunosuppressive drugs, it affects your CD4 population or CD4 effector cells, and that they go down, and then proportionally it appears that your Tregs go up? Do you know anything about like the absolute numbers of the cells? And my other question is, and you might have mentioned it and I might have missed it, but did you see a difference in proportions between ATG treated patients versus basiliximab, right? Because one of them might affect your Treg population, whereas the other one does not.
Thank you for your question. So I think that is definitely valid, like because we're looking at percentages, it could just be an effect of our CD4 T cells going down at 3 months that we did observe previously. We did also see, however, similar fluctuations in the regulatory T cell populations when we looked at the count as well. So one thing that we hypothesized that their increase at 3 months could just be an increase when the immune system is typically hyperactive following transplantation at that point, and then normalizing back to baseline levels at 1 year when the immune system has also normalized. So that was just one hypothesis, but it could definitely just be that the effect of the CD4 count going down as well. For your other question, basiliximab and anti-thymocyte globulin both didn't seem to have any significant effects on our regulatory T cell percentages. So we haven't looked at the counts though, but just for the percentages, they didn't seem to have any significant effect. But we will definitely look into that with the counts in the future.
Thank you for your talk. I have a question because you have seen differences between LT and LB cells. Did you have a look, or did you plan to look about antibodies? Do you have differences about the kidney, the heart, something like this?
I think that could be something we can definitely look into in the future. Right now, our study was just primarily focused on looking at the different fluctuations in the lymphocytes, but I'm not sure if our study was powered to reveal differences in antibody production as well. But that's something definitely interesting to look forward to in the future.
Yeah, that was excellent talk. What are your plans to relate all these changes to the clinical significance or the clinical events that these patients experience?
So currently we are doing our statistical analysis in order to correlate all of these outcomes. So the lymphocyte populations to clinical outcomes. So whether the patient is alive or dead, or whether they experience rejection and their survival post-transplant, that is all currently underway right now. We will look at these lymphocyte populations that I talked about today, and then correlate those with our statistical analysis to those clinical outcomes. That can be one step towards guiding personalized immunosuppression therapy in the future.
Just to make a comment on that, is it would be good to look not just at rejection, but really the complications of immunosuppression as well, which is infection and other allergic disorders. All of that data has been collected, so it might be good to correlate with the other aspect of immune suppression.
Yeah, thank you. I think that would definitely be something we'll look at as well. And I think infection is one of the things that we are looking at. Sorry, I just forgot to mention, but yeah, complications would definitely be something we'll try to look into as well.
No further questions? Thank you, Angela.